Good afternoon, everyone. Welcome to the webinar. My name is Megan. I'm going to be monitoring the questions box for any technical issues you might be having this afternoon. I can also answer questions you may have about the process for getting your CEUs or CPD credits, though I believe there is some information shared at the end of the handout. Carol's actually shared her slides with you. If you look in the handouts section of the GoToWebinar control panel, that's going to be down towards the bottom. But like I said, I'm going to be monitoring for those, and without further ado, I'll let her take it from here.
Good afternoon, everyone. I'm here today to give an overview of best practices when providing mental health assessments to individuals with intellectual disability. So we only have an hour. We're going to pack a lot of information into a short amount of time. So here we go. So the term dual diagnosis typically has always been used for individuals who experience both mental illness and substance abuse problems. However, the term has expanded to include a person with an intellectual disability and a psychiatric disorder. So when I'm speaking of dual diagnosis, of course, that's the population that I'm referring to. Research suggests that individuals with ID are actually more vulnerable to mental illness than individuals without ID, and that they may experience psychiatric disorders at rates that are much higher than what's found in the general population. So in the general population, the experience of mental illness or being diagnosed with a mental disorder in any given year is about 1 in 5 people, or 21%. That number is much higher in the ID population. The prevalence rates vary widely in the research that's been done on this population, and the estimates can range anywhere between 30 to 70%. I think most of the research, though, seems to be right around 30 to 40%. But at any rate, it's obviously at rates much higher than what we see in the general population. But despite having that higher prevalence of mental health problems, people with intellectual disabilities often actually seek and receive professional help much less often than folks in the general population. And there are a couple of reasons why we think maybe that occurs. One reason might be because folks with ID may have little or no knowledge about what mental health treatment looks like, what psychotherapy is, or what it looks like, or how it could be helpful. So they don't know to ask about that type of treatment. And sometimes caregivers just don't have a lot of training in mental health. And this can be a challenging population sometimes to spot mental health issues with. So it's understandable that sometimes caregivers may miss or overlook symptoms that sometimes even mental health professionals might struggle with in this population. So it might be hard to catch it, and then they might not know what to do for folks when they do realize that there's an issue going on. I also think sometimes folks can just get caught between the two care delivery systems, the mental health system and the developmental disability service systems. I just think historically there's not a lot of understanding from one system to the other about what each can and can't provide a person with dual diagnosis. So sometimes I think they sort of gets just sort of stuck in between the two, maybe with neither side providing the services that the person actually needs. And then, of course, we just have a mental health workforce which has received very minimal support and training to meet the needs of people with intellectual disability, and they often shy away from this population out of concerns about competency. I know when I was in graduate school and doing internships, and even in my first jobs, my first clinical jobs, I really had no training or experience in working with this population until I actually started working for a mental health center that was within a board of DD. And then I was sort of on my own trying to figure a lot of this stuff out. Back then, there really was very little information out there to try to get a sense of like what best practices actually are with this population. So I think it's totally understandable that a lot of therapists feel just sort of a little hesitant sometimes about working with this population. But hopefully trainings like this can help with that and have people feeling more confident and excited about working with this population. So, and sometimes I think people in the mental health world believe that the DD system already takes care of mental health issues within their system. And that's just a myth. They do not. There are in Ohio a handful of county boards that do have mental health services as a part of the services that they offer. But even in those programs, they don't have the ability to serve every person with an intellectual disability within their county that would need services. So we really need to expand the mental health workforce out there of people who feel competent in and willing to work with this very underserved population. And part of the reason why there is that uncertainty about treating this population is because there are complicating factors that can make the assessment and treatment of folks with intellectual disabilities a lot more challenging than what it would be in the general population. So, for example, we are used to a person calling up, asking for services, being pretty clear about what it is that's going on and what they need help with, while a person with intellectual disability may come in and may not be able to describe their symptoms or distress. So it really becomes much more difficult to sort of suss out what is going on and how we can be of help. And it's also much more difficult to diagnose mental illness in the presence of limited language skills. And so it really calls for us to then do some investigating and really trying to get a clear picture of what's happening. And as we're doing that, it's complicated because the symptoms are going to present in atypical ways that we're not maybe used to seeing. And these differences in presentation become more atypical as the severity of ID increases. So for example, a person with intellectual disability may not express depression through what looks like low mood, increased sleep, or low energy. Instead, it might be expressed through anger, agitation, and destructive behaviors. Mental illness may also present in just more subtle ways. In part, this is because individuals with ID often have limited life experiences or limited control of daily activities, and that might prohibit the expression of behaviors commonly seen in psychiatric disorders. So for example, like a person who has no control over their financial situation may not be able to spend money or take an impulsive trip across country to another state when they're manic, the way we might see in somebody in the general population who has bipolar disorder. Instead, the symptoms might be a little less obvious in settings that are less stressful or have higher levels of positive support. So, and non-disruptive symptoms might not be regarded as problems at all. So sometimes if someone is just withdrawing or staying in their room, you know, sleeping a lot, taking naps, people just might not realize what that really is, what's really happening. And diagnostic overshadowing is also an issue that clinicians need to be aware of. And that term just describes the tendency that clinicians have to assess individuals with ID a little bit less accurately because the intellectual disability can be such an obvious and important characteristic of the person that it overshadows our professional perceptions to the point where maybe we miss signs of emotional distress and illness and feel like what we're seeing is just some maladaptive behavior that's a part of the person's disability. So for example, a person could be communicating feeling a high degree of anxiety by acting out with aggression and yelling, irritability, and that could just initially be thought of as that's just a part of the behavioral challenges this person has versus this is a symptom of depression or anxiety. So I want to talk just a little bit about the factors that contribute to the higher rates of mental illness, just so that we're
One
aware.
moment, Carol. I'm so sorry to interrupt. Are we advancing the slides? Are we having issues?
Are the slides not moving?
Yeah, slides aren't moving forward.
Okay, hold on. Maybe it froze again.
Sorry to interrupt, but I just had a couple comments about that, so I want to swing in and check.
Let me see. Okay, let's see. I'm just going to move back and see. Okay, are they moving now?
I've just got the title slide.
Okay. Vulnerability, distress. I think,
Nope, still the same.
what do you see?
Just the title screen, the what's going on, intro to mental health assessment.
Oh, wow. Okay. Well, let's just maybe restart it.
Thanks everyone so much for your patience while we sort this out.
Let's just restart. Let's see. Shut that whole thing down. Okay, I'm trying to get it to restart. It seems like it's stuck somehow.
PowerPoint or GoTo?
I think it's PowerPoint. 1 second, I'm going to.
If you're not able to get PowerPoint to cooperate, it seems like everybody's got the handout that they're willing to follow along with. So I think maybe we can move on just for out of time respect.
Just do it that way. I can't get it to restart. That's my problem.
Okay.
I don't know why it's totally frozen. And there's not a, no, I mean, it has to be in the, okay. I just wanted to check one more thing to see if I don't understand. Okay, well, what do people see on the screen? Nothing?
Uh, right now we just have the blank intro to mental health assessment. So
Okay,
you could turn on your webcam, whatever you want to do.
okay. So I just talk and people follow along that way. It's fine.
All right.
Okay.
Again, everyone, thanks so much for your patience.
So sorry, this happened last time too. I don't. Okay. How much time did I lose, Megan, that I need to?
We're still only about 15, less than 20 minutes in. So
Okay. Okay, so I was going to talk about some of the factors that contribute to higher rates of mental illness. One of those things being just a higher vulnerability to stress. There are several factors that contribute to this, um, to the fact that they are more vulnerable to stress. And in part, it's just because they have so much of it. Individuals with ID often experience a lack of control over their lives that can really lead to stress and a sense of helplessness. They might have little say in things that are really important to them, like where they live, who they live with, where they work. For example, I know I've worked with folks who, for example, really disliked a particular roommate to the point where it was a significant source of stress and arguments and tension in the home. However, there just weren't any other group home options or openings at the time, so the person could not leave the home. And even if there were, they were very attached to their other roommates and their group home staff. So I'm not sure that they even would have wanted to move if they could. But it created a huge sense of powerlessness and helplessness, which at times was really difficult for them to cope with. And it wasn't something that was going to change, anytime soon. So just the fact that at times they are just coping with that high level of stress just caused by that limited amount of control over your life choices, and really not having the power sometimes to make a different choice, even if you think that different choice would make you happier. And all change, we know even positive change is stressful just because we're faced with the unknown and we have to adjust to new things. And people with ID experience a very high amount of change throughout their entire life. They're very dependent on caregivers, work supervisors, and family for their overall well-being and safety. So naturally, like these relationships can hold particular meaning and attachment for them. Um, and sometimes, caregivers can very much sometimes feel like family members. And I know I've worked with folks who maybe looked at their home manager as almost like a mother figure, and just sort of assumed that that person was always going to be there in their life, saw them as much more than just like a staff member. But unfortunately, these folks will experience frequent changes in these relationships. Supervisors, group home managers leave and change jobs, and staff at work centers, move on and change jobs. Sometimes even the peers that you're so used to that you've, worked with every day for years decide that they want to go do something different or something changes. So there's just a myriad of ways that change touches their lives, and sometimes that change can be very abrupt and come with little or no chance to say goodbye or have any closure over that, and it can be a very difficult thing for this population. Um, and also, folks with ID often lack the social support and relationships needed to really help buffer the experience of these losses. So they can feel very alone when somebody that they're particularly close to moves on. Transition periods can also be difficult, even for life markers that are typically a time for celebration. Um, Once I worked with a person who graduated from high school, which would be a very exciting time. They were just incredibly sad that this wasn't going to mean that they were going to like pack up and move out of state to attend a 4-year college somewhere and live on a dorm the way that they've seen in movies, and something that they really wanted for themselves, but just was not something that was going to be possible for them. So instead of it feeling like a celebration, it felt sort of like a reminder to them of some of the things in their life that they really wanted, but that felt just like out of their reach. Individuals also may struggle as their siblings transition and achieve their life markers. Like, so when you have intellectual disability and you can't drive a car, you're not going away to college, seeing your siblings do those things, drive a car, move out of the house, go to college, get married, have children, all of those things can be, there can be ambivalent feelings about them, because while they love their sibling and are happy for them, they are also a reminder of things that they would like for themselves. And it can be a sad time, a stressful time. And of course, folks with ID are also just impacted with the societal stigmas that there are regarding a diagnosis of intellectual disability, and sometimes feel embarrassment or shame over their disabilities, which can be a stress that they carry with them and can lead to behaviors attempting to mask the disability or hide it from people. And lastly, they just may have poor problem solving or coping solving strategies. They might not have had a lot of opportunity to learn really healthy and helpful strategies to manage stress. And so they just are unable to manage the experience of life stressors when they occur very well. And grief and loss issues are also an important thing to think about when you're providing mental health care to an individual with ID. Natural losses, such as like the grief that you might feel when a parent passes away, might be felt more acutely by someone with ID than in the general population, in part because people with ID often reside with their parents well into adulthood, middle age, sometimes even older than that. And so they didn't have the chance to experience a typical separation from caregivers. that like you and I might experience, like, you know, when we reached a certain age and we moved out of the house and we got our own apartment, or, you know, whatever that looked like. These folks haven't done that, and they may be well into their 50s still really living at home, very close and dependent on their parent, no experience with being independent from them, and may not feel emotionally able to or ready to do it when their parent passes away. So it can make their death feel particularly frightening and alone. And then on top of that, that loss of a parent often leads to other really significant changes that just further increase that feeling of loss. For instance, if you lived at home with your caregiver your whole life and your parent passes away, then you might have to transition to a group home living environment. And, you know, that change means a lot of other changes, like you're leaving the familiar surroundings of the home that you grew up in, the neighborhood that you were comfortable in, and moving into this new environment with new people. It's a lot to get adjusted to while also trying to grieve the loss of your parent. So just the grief process can be incredibly complicated and something to really pay attention to when you're working with this population. Trauma is also something really to consider. The fact that folks with ID are dependent on others for their care and protection just makes them particularly vulnerable to abuse and a wide range of abuse, including sexual abuse. Research indicates that they experience that abuse at rates that are significantly higher than what we find in the general population. Some studies have indicated that as many as 90% of people with ID will experience some type of abuse during their lifetime. And there's lots of reasons for that, but they're particularly at risk due to these factors. Limited verbal skills, so you might not be able to voice what's happening to someone, lack of understanding of what is happening to them, really not understanding what's appropriate in relationships and where appropriate boundaries should be, whether that's with a staff person or a caregiver or even in a romantic relationship. Sometimes can lead to people experiencing things that make them feel very uncomfortable and violated. And there also can be a real fear of potential consequences for speaking up because of their dependency needs, and also just a tendency to need to please and be accepted by most people, and including their abuser. So they're at high risk for trauma, and they're also more vulnerable to the effects of trauma. Research suggests that this population is more vulnerable to the effects and then more likely to actually develop PTSD. And this is partly because they often lack prior experiencing managing unpleasant or stressful events. So they don't have experience with, don't know how to do that. They have limited system of natural supports. So there aren't people to lean on and process and discuss things with. They might have difficulties with processing what happened to them at all. So all of those factors, you know, combined with limited coping skills, just really increases the likelihood of development of PTSD. So if we know that 90% of folks with ID are probably going to experience some type of trauma in their lifetime, and that they have a higher risk of developing PTSD, it just makes sense that if you're working with anyone who has intellectual disability, that you treat them as if trauma has possibly occurred. You know, so using trauma-informed care is really important and will ensure that services are supportive and avoid re-traumatizing them while they're seeking out the mental health care that they need. So I'm going to talk a little bit about how you can best prepare for the assessment. Some factors to consider about the referral, just to be aware. If you just work in the mental health system, you're used to, and when you work with adults, that people are just calling up and making appointments because they have this identified issue that they want to work on. This is most likely not going to be the case for folks who have intellectual disability. Folks with ID are typically not self-referred. Somebody else in the environment made that referral, often for some type of maladaptive behavior or aggression that has occurred that they are concerned about. So in some ways, that referral may seem like a punishment or a consequence for inappropriate behavior. You know, I hit Mary, and so now I have to talk to this person that I don't really want to talk to. And they may feel some confusion about the purpose of it at all, just in part because of the lack of experience with mental health treatment or assessment, and not really understanding like how you know what they're doing here with you, and how what you do is any different from the variety of different care providers that they work with. It's important to adjust your intake paperwork if you're going to work with someone who has intellectual disabilities. I know that when working with the general population, we typically like to work from a blank slate kind of place and not look through paperwork from former treatment episodes, so that we can avoid the formation of any biases. However, when you're working with this population, it actually is an important part of being prepared for the assessment and making sure that you're able to get all the information that you need. Because folks with ID are often poor historians, they are probably not going to be able to provide you with a lot of the needed information about their history. Like particularly if, you know, like if you work for a mental health, community mental health center, or you work in private practice and you accept insurances, and you know you have that standardized assessment that has to be filled out, all of those areas you have to have the information for, and the person might really struggle to be able to provide you with that information so that you can complete that assessment document. And they also may struggle to recall specific information about their current experience of symptoms. So having a pre-assessment intake form that you ask the individual and like the person that knows them best, maybe a caregiver, fill out together can ensure that you're able to adequately prepare and gather all the information that you're going to need to formulate your clinical impression. It's also a good idea to request copies of prior psych evals and medical assessments. And it's helpful as you're reading through things to try to get an understanding of the person's baseline behavior, because it's important to note that as you're assessing current symptoms, because the maladaptive behavior might be telling you something really important. Sometimes there's an increase in the severity and frequency of a pre-existing chronic maladaptive behavior that occurred after the onset of the psychiatric illness. So it's a clue to pay attention to. Sometimes it comes on after exposure to an acute stressor. You know, it's manifesting because the psychiatric illness has occurred. And sometimes it is just part of the person's typical baseline functioning. But it's good information to have and to be aware of, and to have kind of thought through before you meet with the person. So just something to think about. think through that presenting problem a little bit before you see the person. And of course, like you will continue to think it through as you're meeting with them. But just to sort of have an idea about, like a theory about what you think might be going on that you can really check out. So if the presenting problem in the referral is related to a maladaptive behavior, which it very likely will be. I know in the clinic I used to work in, our number one referral would be some type of externalized behaviors that often were like physical aggression, property destruction, self-injury, those types of behavior, which, you know, if you're not careful and you're not thinking it through, it can overshadow the real issue. So you have to really be willing to listen to what the behavior is telling you versus making an assumption that it's solely related to the person's ID. And just remember, you know, that in order to determine whether it's a mental health disorder is occurring, it's important to be familiar with their baseline, because if you're not familiar with that baseline behavior, it's going to be difficult to accurately interpret those presenting symptoms. So again, like maladaptive behavior could be telling you things. It could be a part of their functioning. It could be because there's a mental health issue going on, and so whatever was happening is happening more frequently, in a more severe manner, or it could be a completely new behavior that's been caused by the mental health issue. Become familiar with the services and supports the person gets. If they're linked to a county board of DD, they'll have probably a multidisciplinary team working with them, and it's just important to have a sense of what that looks like. They could have a service and support administrator. If they're having problems with behaviors, they may have a behavior support plan and a behavior support specialist working with them. If they live in a group home, they'll have home managers and staff there. If they work in work centers, they'll have staff there who are working with them and know them pretty well. There could be recreational activities that they're involved with. They could have job coaching. There are just so many different types of support that they could be getting. And it's important to have a clear picture of what all of that looks like as you're doing the assessment and then making decisions about the types of recommendations that you're going to make for the person afterwards. At times during the assessment, the person might provide inconsistent information due to memory failure or attention span issues. So it's a really good idea to plan to involve collateral data sources in the assessment. Caregivers and service providers really are often able to provide a wealth of information. They could give you important observations about sleep, changes in appetite and weight, changes in baseline behavior, and also just the presence of family members or caregivers can provide, I think, significant and helpful insights into the person's present circumstances and just the relationship that they have with those people, you know, can give you an idea of how supportive or not supportive those relationships are for the person. So I think it gives you lots of good information and clues into the person's life. Make sure that you plan for enough time, especially because it's not just going to be the client. There'll be some you know, hopefully somebody there to provide some collateral information. I would plan for 90 minutes or maybe 2 shorter appointments. And as you're planning for the time, just thinking about like the issues that will be factors, you know, and how much time something takes. So there could be communication issues that you have to work through. If there are more than one other person coming, depending on the person's intellectual disability, like their attention span could be pretty short, and so they might not be able to do like 90 minutes. It might have to be 2 smaller appointments, but just sort of trying to think that through. Set the stage in a way that will help the assessment be the most productive and make the person the most comfortable. If they use a communication device, be sure that it will be present with them during the assessment so that they can use it. And that's something you should specifically ask about. I definitely have had people come for assessments and staff forgot to bring like their communication device. So it's just really important to stress the need to have that there if they use that. Make sure that you have like a flexible office space where you could do the assessment with a variety of seating options so the person can be comfortable. You know, maybe single chairs with and without arms, or that are hard or soft. And be aware if there's any physical disabilities so that you can ensure that there's enough space in your office for wheelchairs or walkers to maneuver around in a comfortable way. And also just plan to minimize distractions. You want to make sure that your office space is suited for a person who might have a shortened attention span and may be easily distracted. So put away items that might compete with you for their attention and focus, so that you're able to accomplish what you're trying to accomplish during that assessment. And you might find that the person is getting distracted anyway, despite your best efforts. And so just continue to just refocus attention at regular intervals as needed. The interview itself, just some things to think about during that interview. Start with asking the person if they understand why they're meeting with you and explaining the purpose of the assessment and what to expect. Prepare them for the amount and type of questions that you're going to be asking, and make sure that you provide an out for answering difficult or very sensitive questions. And make sure that they know, like if you do have those collateral data people there, that they can decide whether they want to answer those kinds of questions with those people present or not, and that you will set aside some time at the end of the assessment just for the two of you, asking those collateral data sources to step out, so that there is some time for them to share with you things that might want to keep more private or might feel more sensitive to them. Remember that they probably didn't self-refer, so if someone else made that referral, explore how they feel about it, how they understand why it was made. Provide reassurance that they're not being punished if it's needed, and give some education regarding what's going to come next. If it's psychotherapy, spend a few minutes just explaining what that looks like, a safe place to talk freely about thoughts and feelings and learn to solve problems, and why people go, providing a private and confidential place to get support and learn new things. They really might have very little to no idea about why they're with you, and then what comes afterwards. So giving them that information can be really helpful and set the stage for successful remainder of their mental health journey with you or your agency. Most patients with ID have much better developed receptive language skills than they do expressive language skills. So even an individual who's nonverbal or one with severely limited language skills may still understand everything that other people are saying to them. So be careful about that. If you are doing an assessment with someone with limited verbal skills, you can sometimes use observational skills to sort of make this determination. For example, if someone in the room is describing a behavior that occurs at home, and then the person begins engaging in that behavior, then it's evident that their receptive skills are well developed. But regardless, all comments to anyone in the room should be delivered with the expectation that the person understands and will be picking up on being ignored or disrespected. So just be aware of and be careful with that. Address the communication issues very openly. You want to, like off the bat, establish that the cognitive deficit is a legitimate and neutral topic for discussion and exploration, and then take ownership for ensuring that both you and the person understands what each other is saying. And then as a part of that, like also taking ownership for any miscommunication that can occur. So just regularly kind of checking in. Do they understand what's being said to them? Ensure that they feel comfortable letting you know if they do not. And that that's really okay, and that you're going to be checking in periodically because you really want to make sure that they feel comfortable and they feel heard. And so it's just a process, I think, of negotiating this issue just very openly with the person. And that way you can, be careful to really like feel like you're working as a team on this and helping you not to like overestimate or underestimate their abilities, but really to be clear about where they actually are. Adjust your language. You want to make sure that you're speaking in a way to meet the needs of a person who thinks in more concrete terms. So avoid idioms, metaphors, analogies. Don't use hypotheticals or abstract questioning. A person's not going to understand those. Be specific as possible. Use illustrations when you can. That can be very helpful. And limit your use of jokes and or humor, which could be taken pretty literally, depending on the person. Make sure that you're matching your questions and answers with their individual expressive language skills, so pay attention to how they're speaking, and then you try to match that. Shorten your sentence length. Only ask one question at a time. Don't ask double-barreled questions that have like two questions in one question. And make sure you're using the same descriptor words that they're using, so that like in that way you're speaking the same language. Because you're going to be doing a mental health assessment, it's important to ensure that you guys have a shared language for exploring mood and feeling states. So if you have like a feelings chart, or you can print one off the internet, that would be very helpful just to have handy. And you can have the person sort of identify and label the feelings on there, so you can just sort of make sure that you're on the same page about that, using simple language and their wording when you're talking about feelings. So like mad, sad, scared, things that are easily understood. Make sure that you're using a trauma-informed approach. Their consent should be obtained before you talk to others in the room or you broach sensitive subjects. So for example, you can just ask, like, is it okay if we talk about blank? Or I'd like to ask you some questions about this. Like, is that okay if we do that now? And ensure that you're always talking to the person versus about the person. Even a person who has very limited language skills. You may need to set boundaries for the involved parties that are there. You want them there, you want them to give you information that's helpful, but you don't want them to speak for the person. So just maybe setting up those expectations about like being so thankful that they're there and it's very helpful. And when you have questions for them, you will ask, and for the most part, you're going to be getting the information from the patient directly. And then because they're there, you just want to be alert for any distress that the person might show. If any of the information being shared is critical in any way, and it appears to be upsetting for the person, then you may want to like take a break there and get that information separately without the person. And allow time for a break if needed. If someone is just getting overwhelmed or really bored or just like struggling with their attention and focus, they might just need 5 or 10 minutes to just sort of to relax, or take a quick walk around or get a drink of water. And when you start off with the questioning, start off nice and easy. Begin with general questions about non-threatening issues so that you can help the person feel comfortable. And it also gives them just practice in answering questions and answering them accurately so they can feel good about that and develop confidence in their ability to do this assessment with you. And it also just helps establish that rapport between you and the person. So start off that way. Plan to ask questions about more sensitive topics much later in the interview, after you feel like that therapeutic alliance has been pretty well established. I'm going to go over some factors that could affect the presentation of symptoms just for you to be aware of. The first one is intellectual distortion. So a person with intellectual disability might have like a diminished ability to use their abstract thinking and their communication skills. And then that in turn limits their ability to really accurately and fully describe what's happening with them internally. So a person might report feeling sick, for example, when they're really feeling anxious. They also might have difficulty understanding questions regarding illnesses or experiences, and that can lead to misunderstanding and incorrect answers to questions. So, for example, a person might say yes when asked if they hear voices because what they're telling you is that their hearing is okay. So you just want to pay attention, know that this can happen, and then explore things maybe a little bit more so that you can be sure that you're understanding what's really happening, what they're trying to tell you, and that they're understanding you. Baseline exaggeration, we talked about that a little bit before, but it's what you're looking for is subtle changes in behavior that could possibly initially have been overlooked due to their usual functional limitations. So, pre-existing difficulties with thoughts, actions, and behaviors really can be exaggerated at times of stress and upset. So, for example, maybe the only sign of depression is someone unable to talk is an increased frequency of self-harm. And so maybe they bang their heads sometimes, occasionally, and now it's happening all the time, every day, for large parts of the day. Psychosocial masking. People with intellectual disabilities may not have the same opportunities and experiences as people in the general population. So because they have that supported structure in their environment and their own lack of experience in life, it can dampen the expression and detection of their mental health symptoms. So where symptoms might seem simple or unconvincing, you really should consider them in the context of a person's developmental level. For instance, mania might present with the belief of, I can drive a car, and paranoid delusions might present like just with thoughts that people are telling lies about them. So things might appear a little more simple, and so that, it's just important that you're paying attention to that and not just disregarding things because they're less colorful. Cognitive disintegration. Due to the lack of cognitive reserve, people with ID may dramatically decompensate under stress. They might lose skills that they normally have, become mute or hallucinate, might have difficulty communicating feelings of stress, and can result in like anxiety-induced behavior like aggression or acting out, those types of like maladaptive behaviors. So when that happens, if you're not careful, it can lead to incorrect diagnoses of things like psychosis, bipolar disorder, dementia. So you just want to be aware that if someone's under high stress, like this is something that can happen, and does not mean necessarily that it's one of those other diagnoses. Acquiescence is something to be aware of, and that's just the fact that individuals with ID may demonstrate a tendency to agree with any statement given to them. It's actually negatively correlated with IQ, so the patient with more severe cognitive deficits is actually less likely to acquiesce. But it's more common if the interviewer is viewed as an authority figure, as you probably will be as the person doing the assessment. And so the person really might want to gain the approval of the interviewer. And if there's comprehension problems, that can feel really embarrassing to the person, and they may try to cover that up or hide that by just agreeing with things. So the interviewer really should just anticipate that the person might fear consequences or negative responses or disappointment, and just watch out for that and check for that. And because of that, really be sure, like we never should ask leading questions, but really like with this population, be very careful about doing that, asking questions like, you knew what you were doing, right? And sometimes if you're asking a question and you're not sure, like if you're paying attention and maybe the body language isn't matching the content of what he's saying, like you ask, are you happy where you live? And they say yes, but they don't appear very happy, then check that out. Maybe they're just giving you the response that they think you want. So ask it in a few different ways. You know, are you happy about living where you live? Are you unhappy about living where you live? Would you rather live somewhere else? You know, like just asking it in a few different ways to see what kinds of answers that you get. Form your questions thoughtfully. And just be aware that the questioning methods you use can lead to complexities and different outcomes when working with people with ID. If your questions are unnecessarily complex, that can just be really confusing and embarrassing sometimes for folks who just really want to please you and appear that they understand you. So keep questions simple. If you're asking a person about their preference, an outcome, or an action, just pose no more than two options in one sentence. So, for example, say like, would you like to play Uno or draw, rather than would you like to play Uno or draw or do a little of both. Or don't say like, how do you feel about starting your job tomorrow and meeting new people? Instead, ask each question separately. So just remember that when questions are too long or the sentence structure is too complex, the patient might only focus on some of the words or phrases within the question as opposed to the concept as a whole. So most individuals with ID are really taught and trained to get along with other people and to respect people in authority. So they're just much more likely to try to give socially desirable responses and to acquiesce. So just, I guess the message here is just take more time to investigate and explore it if it's in question, and be thoughtful about how you're asking the questions. Serial order effects can also come into play when you're asking questions, so it's just something to be aware of. This is the tendency to answer with the last choice that was given. So the option offered last tends to be chosen because it might be the only one that they're able to recall as the one that versus the one that really represents what they think or how they feel. So one strategy to eliminate serial order effect during the assessment is to repeat the question and then vary the order in which you presented the alternatives. So you can be sure they're not just agreeing with you with the last thing that you said, like, are you sad or happy? And if they say happy, then are you happy or sad? And make sure that it's still happy. Also, just following up with either or questions by asking further examples and elaboration can be really helpful. Like, do you have a girlfriend? Yes or no? And tell me more about that. Describe that to me. I have some slides that are about symptoms, just sort of what different disorders might look like in this population, but I know that we're out of time. So I could just keep going and finish, or I could stop here, and this information is on the slides and available for people to see. Megan, do you have a preference?
I don't have a preference. It looks like we are getting a couple of comments that says we can go ahead and finish.
Okay,
I do apologize. My internet connection dropped there for a couple of minutes. I'm back in now.
okay,
So I'm still monitoring. I think I did lose some of the questions that had popped up in the box, so I apologize about that. But yeah, it looks like we can. Let's just go ahead and finish out the rest.
okay. We're almost we're almost done. I know it's a lot of information, and I'm just trying to give a bare overview so that you have a general idea, but I think it's all like so important. Okay, so in the assessment of symptoms, just some things to think about, and I'm just going to briefly touch on them, not go into anything too in depth, but one of the most important things to know is just that just in the same way that mental health conditions can be overlooked, so can medical issues with this population. And so you want to rule out any kind of medical issue that could be occurring that is appearing, you know, so like the person is experiencing symptoms that appear like a mental health issue, but it's actually something else that's happening. So there could be GI issues, diabetes, low blood sugar, dental problems and pain is a common one. I definitely, like I worked with a person who had diabetes, and when their blood sugar got actually like really low, they really became very angry and agitated, and had a lot of like aggressive behaviors. And really, like when that started happening, people started to realize what that was, and then could treat that. But that had nothing to do with mental health issues. That was her blood sugar. So just remembering that often medical issues are undiagnosed, and the people aren't able to self-report those physical symptoms in the same way that they sometimes struggle to report their psychiatric symptoms. With depression, in your assessment of depression symptoms, I want you to just keep in mind that individuals with ID might be more likely than non-impaired adults to experience an irritable mood rather than a sad mood when depressed. It's very common to see angry, aggressive, self-injurious behaviors when someone is experiencing a depressive episode. So many referral problems are initially presented by staff as non-compliance, temper tantrums, self-abuse, you know, just like having a behavioral outburst for no reason. And sometimes folks with ID who exhibit such behaviors are really just, they're struggling with depression. And frequently, although not always, have histories of trauma as well. So just remembering that the irritable mood is important. Excessive reassurance seeking has also been associated with depressive symptoms in persons with ID in some of the research that's been done. And some of the other things that might happen, which are similar, changes in appetite, insomnia, those things might look a little bit different because of the world that folks live in. So if you live in a group home and you have staff that's helping you and, you know, helping make the food, getting the food at the table, getting you to the table, is, you know, can look a little different than someone who just lives alone and just like they're just not going to the grocery store and they're not making meals. So this can be masked a little bit and might look more like a person refusing to go to the dinner table refusing to eat once they get there, or if their change in appetite is actually that they're more hungry, they might start stealing food or hoarding food. So those are just some things to look for if you hear that happening. So just asking, not just has there been a change in appetite, but what is the mealtime routine and how is that going? Are there any issues with that? And that is similar also for insomnia and sleep issues. Sometimes behavioral issues can happen at bedtime, which is masking that difficulty with sleep. So, a person with insomnia might have a behavioral outburst before bed because they really don't want to go get in bed because they know that when they get there, they're just going to toss and turn all night versus talking to someone about that and sharing that. Suicide is actually a really important topic to discuss and for us to consider. Like in 2020, I think suicide was the 12th leading cause of death for all ages in the US, with an estimate that about 1/3 of all people have suicidal ideation at least once at some point during their lifetime, right? And so if we know that, and we also know that individuals with ID experience higher rates of psychiatric illness, and they experience depression in the same way that, in rates that are similar to individuals in the general population, then it just makes sense that we should take the possibility of suicidal ideation, suicidal behaviors very seriously. Lethality assessments are critical because we know that having a cognitive disability does not protect a person from self-harm, and individuals with ID do in fact experience suicidal thoughts, suicidal planning, and suicide attempts. And it's also believed that the experience of depression and suicidal ideation are often missed by caregivers and family members. For the reasons that we've already talked about before that can make this so complicated. And the individual does not have the ability to report their symptoms or distress, or they might experience them in ways that are presenting in a very subtle manner, and so that they're easily overlooked. So when someone comes in for an assessment, suicidal ideation might not be on anyone's radar. The depression might not be on anyone's radar, and it might not be what's reported to you, but it's really important to explore and find out, what's happening. There have been research and studies that have shown that actually children and adults with ID are at an increased risk for suicidality, and one at-risk group that is largely overlooked when it comes to this crisis is autistic people. Research shows that autistic people are actually 6 times more likely to attempt death by suicide and up to 7 times more likely to die by suicide compared to those who are not autistic. The risk of death by suicide is even greater among autistic people without intellectual disabilities, and the greatest risk is among autistic women who are 13 times more likely to die by suicide than women who are not autistic. So it's not entirely clear why autistic people are at this increased risk of having suicidal thoughts and behaviors. It's believed that it could be a number of factors kind of at play. For example, like negative childhood experiences, being bullied, things like that have been associated with suicidal thoughts and behaviors in autistic youth. And in adults, loneliness, social and communication difficulties, feeling like a burden to others, and lack of support have also been things that have been linked. So it's really important to be aware of these issues and to be screening folks on a regular basis. So there's not a lot of research in this area, but there is some, and the clinical studies that do exist describe these things that are listed here as risk factors for folks, right? So The highest rates of suicidal behavior in persons with ID tends to be people with mild ID, and you know, the lower your, like the higher functioning you are, the more at risk you are. Young adults living independently without supports and people sort of around, that can be a protective factor that you lose when you're living alone. Previous history of suicide behaviors. If a person already has a mental health diagnosis, can be a risk factor. A history of sexual abuse or trauma, lack of social support, feeling alone. Recent psychosocial stressors is a big one. And in fact, recent psychosocial stressors is also a predictor for a depressive episode just in general. A person who has had a significant psychosocial stressor in the last 12 months has been, they found that those folks have a much more higher likelihood of developing a depressive disorder. And chronic medical conditions also are something to consider. Here are just some of the general, some other risk factors that can be at play here. Being bullied, being impulsive, relationship problems, significant losses, legal problems, exposure to suicide or death of someone close, substance use, chronic sense of powerlessness, expectations of individual capacity isn't matching reality, and understanding of death. And actually, we know from some of the things that we've talked about so far that many of these things are factors that individuals with ID all experience on a pretty regular basis, you know, and they put them at risk for really serious consequences. So when you're assessing the risk, I just think it's important to remember that you have to be careful about how you are going about it. Remember that acquiescence can affect the answers that you're getting when you're asking these questions. So be cautious when you're assessing, that you're exploring it in a very neutral manner, and then investigate their responses to be sure that you're understanding what they're telling you. So, for example, if you ask someone if they have thoughts of harming themselves, and they say yes, that could be because they're having thoughts of harming themselves. And it could also be because they think that you want that yes. They're just trying to give you the right answer, but they don't actually wish to harm themselves. Or they could agree with you that they are safe as a way to please you when they actually aren't safe, or deny active suicidal ideation because they don't want to disappoint you or experience negative consequences in their environment. So just be aware of those things, be thoughtful and careful in how you're asking the questions and assessing. Look out for psychosocial masking. Just that because of their limited social experiences, the content of their psychiatric services might not be as colorful. So it's just important to consider that. Like, for example, I had a client once who was in a wheelchair and lived in a cul-de-sac, and they rolled themselves into the empty cul-de-sac. And I don't think staff thought much of that. There wasn't any traffic in the cul-de-sac. The person wasn't like at risk for harm, but the person didn't know that. And to them, that was actually an attempt, which might not have looked like an attempt to the people around them. But it was actually a signal that there was really a significant depression happening, and the person needed some support. So It's just essential that we do a thorough risk assessment in the beginning of treatment. And again, if you become aware of sexual abuse, family instability, recent psychosocial stressors, any of those things, particularly for folks who have mild ID, have autism, have a lack of social support, have comorbid psychiatric disorders. So just something important to consider. Anxiety often shows up as behavioral outbursts and irritability. There can also be avoidant behaviors, especially when they represent a change from typical behavioral patterns. So someone who usually goes to work and likes work or school and suddenly doesn't want to go and is refusing to get on the bus or refusing to get dressed. Vague or inconsistent, multiple somatic complaints might occur. Someone's just saying like their stomach's upset, they have a headache, those kinds of things can be a sign of an anxiety disorder. Insomnia, which again, we talked about this a little bit before, that might look like avoiding going to bed or behavioral outbursts before bed, because just not wanting to have to go to bed because knowing they won't be able to sleep. And there could be just the physical symptoms to be on the lookout for, like increased urination, muscle tension, GI issues, chewing nails. Observing what's happening there can be helpful as you're trying to formulate like the full picture of what's going on. Can help you sort of put the pieces of the puzzle together. Individuals with ID who are suffering from PTSD might complain of anxiety and insomnia. That in terms of the efforts to avoid the reminders of abuse, sometimes that can manifest as behavioral outbursts or display of aggression when you're present with situations that are reminiscent of that. However, sometimes there can't be an effort to avoid the abuse. There might be no opportunity to avoid specific situations, places, or people, because you might not have a lot of say in where you go each day. And so for that reason, there might be aggression and irritability prior to going to wherever the thing is that is stressful, so maybe something happened at work, and so the person doesn't want to go to work. So then in the morning when they're getting dressed, there's a behavioral outburst, and that is their effort to avoid having to be exposed to that trauma. Sometimes it can be hard to put those two things together. Flashbacks may manifest as displays of unprovoked aggression, increased anxiety, fearfulness with no discernible cause. So just paying attention to that. And behavioral symptoms, just in general, such as irritability, aggression, restlessness, are more common for folks with ID who have PTSD than it is in the general population. Mania can manifest in different ways for people with IDD. Irritable mood, labile affect, overactivity, and decreased sleep are all core clinical features of mania in this population. So that's something to look for. The cognitive symptoms of mania, like inflated self-esteem and grandiosity, might be affected by the person's developmental profile. So, for example, it might look a little damper or flatter than what you're used to seeing. So could just be claims of skills the person does not have, like I can drive a car, something that just seems kind of simple, but actually is a sign of that inflated self-esteem and grandiosity. Or they might exaggerate social events. Delusions may also be simplified. Pressured speech might appear as increased vocalization. So they're either having more vocalizations, or it's louder than it usually is, or gesturing in individuals with limited expressive language. Those things are all important things to pay attention to. The increase in goal-directed activity also might look a little bit different. Folks might appear sped up, have difficulty sitting still, walk rapidly. They could be very intrusive, like not respecting boundaries, or be more physically active than they typically are. And the increased involvement in pleasurable activities also might look a little bit different. So, for example, instead of spending wild amounts of money in your bank account that you can't really afford, maybe if you're bipolar and in the general population, folks with ID are often on a fixed budget, and so that has to be taken into account when you're assessing for this. So it could look like stealing even a small amount of money or a few items, or it might be someone has a small amount of money that's like in their budget for the week, and they spend all of that in one day, which doesn't seem like a lot of money and maybe isn't a big consequence for the person, but that's only because their environment is shaped in such a way that it has to look like this. There's no, like there are, it's sort of, they're protected from having those really sometimes very big and awful consequences that can happen for people, but they're still important signs that the person is struggling and may need help. Psychosis, when you're trying to assess whether someone with ID has psychosis or not, these are just some of the things that maybe to look for. So sensitivity to brightness of lights or conversations occurring, maybe feeling like overstimulated by those things when they weren't before. It's like a sudden onset of that. All of a sudden, they're not able to perform skills that they used to be able to do, like they used to be able to dress themselves and take care of their hygiene just fine, and now they're just not able to do that anymore. Difficulty initiating activities when they don't appear depressed or anxious. And evidence of hallucinations or delusions could look like any of these things. It could be talking to self. It also could just be staring off into space or appearing preoccupied, repeatedly brushing unseen material off your body, grimacing or wincing as though they're smelling or tasting something foul, or shadow boxing or striking out for no particular reason. And delusions could manifest as any of these things, thinking a TV or movie hero is real and is part of their life, thinking that people are talking about or trying to hurt them, stating or believing that their food is poisoned, glaring with intensely angry facial expressions at strangers or previously liked individuals. So if you see any of those things happening, it's certainly something that should be investigated in terms of if they're reality testing. Substance abuse is an issue with folks with ID, so something to be aware of and not just like assume that it's not happening. Research indicates that the prevalence of substance abuse is about the same, maybe slightly lower, but close to the rates found in the general population. The characteristics that really impact the susceptibility to substance abuse are like that sort of outer directed orientation and desire to like people please, which makes them more susceptible to peer pressure. And then that desire, to acquiesce makes it much more difficult to identify and resist manipulation when it occurs. So that's definitely a factor, along with just poor insight regarding the possible negative consequences of substance abuse. So, and the people who are most at risk for substance abuse, according to the research, are folks with mild ID, folks that are living in the community versus in a structured setting, and young adults and adolescents. So So this is the end of my presentation. I do want to just list here some clinical resources to consider just for your own practice. We in Ohio have NAD, the National Association for the Dually Diagnosed, which is a very helpful not-for-profit association. I think it was established in 1983 for professionals, care providers, families. Their goal is to promote the understanding of and services for individuals who have ID and mental health needs. And I know when I first started working with this population, I found the information on their website tremendously helpful. They offer conferences, trainings, they have journals, webinars, consultation services. I got a lot of great books on the provision of mental health treatment to folks with ID from their website, like throughout my time working with this population. So it's just a great resource to consider. Another one is that there's a diagnostic manual for intellectual disability. It's a clinical guide for diagnosis of mental disorders in persons with ID. And what they've done is they've taken the DSM-5 and then shown adaptations to when you're working with someone who has ID. So they will show you what the adaptation is to the criteria and help you get clearer about what you're looking for. So that's out there and is a really helpful a resource to consider. And here's like an example of that. The DSM-5 criteria says, like, for depression, it's 5 or more of the following symptoms have been present for the same 2-week period. And they don't list irritable mood as one of the symptoms. And in the DMID, they have changed that to 4 or more symptoms, and they've added irritable mood because that is such a common symptom for folks with depression who have intellectual disability. So just a good resource that's out there if you're going to be doing assessments with this population. I would highly recommend it. And I'd like to thank you all for being here with me for an hour and a half. I apologize for the PowerPoint getting stuck, but thank you so much for sticking around and bearing with me. I've enjoyed sharing this information with you today.
Thanks, everyone. So for those of you who have not attended a webinar with us before, you will be receiving an email about an hour after the webinar's conclusion, actually probably in about half an hour. And that is going to have a link to DoDD My Learning and an enrollment key for you to go ahead and do the survey and get your CEU or CPD credits. So everyone, have a great day.